Great. I'd like to start by thanking you very much for inviting me to come and speak about this exciting research project, which I'm really looking forward to doing. And as you've heard, this project I'm doing is about well-being and mental health of young people with inherited macular disease. So I think it's good to start off with some definitions. Let's start by thinking very big and thinking about what health is itself. The World Health Organization define health as being a complete state of a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So this is almost philosophical, I suppose, but it's saying that to be healthy and to be happy, we need to be have well-being as well as just being free from disease. And well-being is one of those words which is used a lot. You hear it huge amounts at the moment, but I thought it'd be useful to go back and just define what I mean by well-being for the purposes of this talk and what other people mean by well-being. So if we look at the Oxford English Dictionary definition, well-being is a state of being healthy, happy or prosperous, or physical, psychological or moral welfare. But I think that's been changed a little bit over time to be more health specific and more mental well-being specific. So the Department of Health, for example, say that well-being is life satisfaction, including positive emotions and the feeling that life is meaningful. So if you listen to philosophers or to psychologists, they talk about positive emotions being hedonic well-being and a meaningful life being eudaimonic well-being. These sort of philosophical, psychological terms which are used. So it's still a bit of a sort of an abstract concept, but this is something which we can measure. And there's standardized ways for measuring somebody's well-being. And one of the most common ways of doing this is with questionnaires. And the one we're going to use is called the Warwick-Edinburgh Mental Wellbeing Scale. And this comprises 14 questions that ask people to rate their own life on questions like, I've been feeling relaxed, and they can answer always, generally, rarely, never, or I've been feeling optimistic about the future. And these sorts of questions are ways that we can measure scientifically what somebody's well-being is like. And these have been used lots and lots in lots of research for all sorts of different health conditions, for different life situations and so on. And that's what I mean by well-being for the purpose of this talk today. So from the title of this talk, as well as well-being, I'm also going to talk about mental health and mental ill health. And for mental ill health, I mean a sort of range of mental health problems which can cause distress and interfere with somebody's daily functioning. So as you know, examples of mental health conditions include things like schizophrenia, eating disorders, bipolar disorder. But specifically today, I'm going to speak about anxiety and depression. So that's the area of this talk today and the area of the research which I'm currently doing. A few more definitions before I get going on the project. Young people, well, we all know what young people are. But specifically, the types of young people we're interested in for this study are adolescents, who are aged between 10 and 19, and emerging adults. So emerging adulthood is a new sort of category of people which you may not have heard about before. And this is particularly in high-income countries. We know there's this transitional phase between adolescence and adulthood. So this is the time at which people often have different romantic partners, they have different jobs, they're still sort of transitioning between being an adolescent and being an adult. And this is seen as being between about the age of 18 or about the age 29. It's not something I'm really going to talk about today, but it's also really relevant for clinic design and for how people get seen in hospitals. So we know, for example, that somebody who is 21 is very different to somebody who is 14 in terms of their needs, their expectations, and what additional help they'll need. But that same person is very different to somebody who is 70 years old. So at the moment, people quite abruptly go from a children's clinic straight into an adult clinic, which often in macular disease is full of people who are much older with macular disease. And we are aware that there is this unique group of people around about in their 20s who need additional help and support. And that's a big area of research at the moment. And then the last definition for my title is inherited macular disease. You're in the inherited macular disease stream at this conference, so I'm pretty sure I don't need to define that. But one thing I would like to point out is that we often hear about inherited macular diseases as being called rare diseases. So looking at Stargardt, ABCA4, about 1 in 10,000 people have Stargardt disease. And yes, that does classify it as a rare disease. But I'd just like to remind you, this is by no means you're by no means alone if you have inherited macular disease. Just from statistics, we know that means about 900 people in London and about 7,000 people across the UK will have Stargardt disease, let alone these other inherited macular diseases like Best disease and so on. And that means about 75,000 people across Europe have inherited macular disease. Of course, there's nowhere near as many as the people who have age-related macular disease. There's about 67 million people have AMD across the EU, but these are still large numbers of people. Okay, so hopefully that's helped to define some of the terms which I'm talking about today. I'd now like to move on to talking about mental ill health and low levels of well-being in people with vision impairment. So when we look at this from a research point of view, there's a few difficulties because mental ill health is a very, very common condition. We know that about 6% of people every year will experience depression, and a similar number will have anxiety every year. Of course, there's interaction. A lot of people with depression have anxiety. A lot of people with anxiety also have depression. But we're talking about at least 1 in 20 people across the population will have some signs of depression or anxiety every year. And one thing which people have asked is obviously if you have a condition which causes vision impairment, such as macular disease, we know this impacts on all sorts of areas of life, but does having vision impairment, specifically does having macular disease, affect your mental health? Does it make you more likely to have depression or anxiety? Well, most of this research to date has been done in age-related macular disease, so in an older population. But it does appear that depression and anxiety are more common in people with macular disease. So these papers are both systematic reviews, which have looked at large numbers of different research studies. And pooling all the data from these different studies, it seems that around about a quarter of people with macular disease, age-related macular disease, have depression. And around 20% of people with age-related macular disease have anxiety at any time. But of course, these, as I say, these pool lots of different papers, and different studies have found different prevalence figures. And that depends very much on how the questions are asked and how they've recruited the people for the study. So the numbers do vary across different studies. A large study from the UK, which was done a few years ago by Claire Nollett, Tom Margrain and colleagues in Cardiff, showed that 43% of people with age-related macular disease had depression, but only a quarter of those were receiving treatment. So this is a large number of people, and as I say, that again in the older population. Looking specifically now at inherited macular disease, which I know is what you're interested in by being here and listening to me talk about this, there's only really been small studies so far in people with inherited macular disease. It does seem that there is an increase in depression and anxiety compared to the general population of people with inherited macular disease. But as I say, these very small studies, they're both in Stargardt disease specifically, and they're either very small case series or they're focus group based studies. Now, one of the problems as a researcher which I have with looking at mental ill health in eye disease is that we don't know quite what causes what's cause and what's effect. So we don't know whether having macular disease causes depression or anxiety directly, or whether people experience depression and anxiety when they have vision impairment from macular disease because they're no longer fully able to participate in society or to do everything which is enjoyed. Now, this reflects two fundamental differences of how people think about disease. The medical model of disease is where we think about the disease as causing a direct impact on people's well-being. And the medical model says the best way to deal with this is to treat disease, to reduce disease, and to make it disappear. And of course, that's very important. But the other way of looking at this is the social model. And this is where we say that having a condition like macular disease causes these problems because people are not able to fully participate in society. And the best way to address that is to remove barriers and to make things easier for people in society. So the way of approaching things from the social model is to make sure, for example, that every television program and every theatre production has audio description, that every staircase around the country has very, very high contrast markers, that every public transport system has an open system which will allow, which will speak bus stop destinations, for example. So these, of course, are not in isolation. There's two very different important things, but I think I'd like to invite you to think about these two things when we talk about mental health and well-being: what's caused directly by the disease itself, and what's caused by problems in society that makes participation difficult when you have that disease. So just to summarize what I've spoken about so far, we know that depression and anxiety are very common in our society. We know they are more common in people with many types of vision impairment, particularly age-related macular disease. But we don't yet know a lot about mental health and well-being in people with inherited macular disease. And we don't know whether having macular disease reduces well-being directly as a consequence of the disease itself, or indirectly because of the limitation of things which you can do, perhaps if you have vision impairment. I hope that makes sense so far. So, more interesting questions, I think, are how we can help people who have mental health or have reduced well-being when they have vision impairment. So, lots of research on this, all sorts of different things which have been suggested as helping. Some things you may not think about as treatment at all, like exercising, like having outdoor activity, and like having increased social contact with neighbours, with friends, and so on. From other areas of vision impairment, we know that other aspects of care which are provided in hospitals and by local councils can help well-being. So having low vision appointments, low vision clinic appointments, having counselling, of course, and having occupational therapy, mobility training, all of these sorts of other interventions which you may have experienced yourself. We know this gives people the capacity to solve problems, to participate more, and to improve their well-being. Problem-solving therapy is something which has been researched. So problem-solving therapy is a sort of talking intervention which is delivered by a trained therapist. And over 6, 7 or 8 sessions, people have a method for sharing their problems and for overcoming problems associated with their vision loss. And the other thing which has been researched quite a lot, particularly in the Netherlands, is a program called Stepped Care. And this is something whereby well-being is helped by a sequence of stages. You progress to the next stage if the first one doesn't work. And that starts with things like self-help based on cognitive behavioural therapy techniques, which you might have heard of, problem-solving treatment. And then if these things don't work, they're going up to a referral to a general practitioner and having medical treatment and counselling treatment provided if needed. So the way stepped care works is people have their well-being assessed or their depression or anxiety assessed, and then at each stage after each intervention it's checked again and people are moved to the next level of care if needed. Of course, if there's an emergency, if there's a crisis, if someone's very, very distressed, they go straight to the top levels. They don't have to go through the lower levels of care first. So that's what we do if people have mental ill health and display signs of it. But something which is really, really interesting, I think, is whether we can reduce the signs of these things before they happen. So that means perhaps if somebody has a very, very early stage of vision impairment, a very early stage of inherited macular disease, maybe even a diagnosis, can we offer a package of things to make sure that these people, as the disease progresses, don't end up with mental ill health, with depression, with anxiety, or with reduced well-being? And there's a few things. We don't know whether we can do this, but there's some encouraging signs in the literature scientifically. So exercise and fitness initiatives we know that help. And this has been used across different types of health conditions. And these are things like social prescribing. This is something which is offered in GP surgeries, but they will make sure that people participate in different activities, including exercise, or exercise on prescription, which you might have heard of. Does mentoring help? So having somebody perhaps with the same condition who's had the condition for longer, or peer support by somebody else of a similar background with a similar condition. These are things which are again being researched at the moment with some encouraging signs that these may be helpful. There's some evidence emerging that having counselling can be helpful when it's offered to everybody with vision impairment. Again, this is some really nice work from the Netherlands, from Ruth van Nispen and Hilda van der Aar in Amsterdam. And there's some growing consensus that having counselling is a good way to prevent mental ill health rather than waiting until people show signs of depression or anxiety before offering counselling. So I hope that's given you a little bit of a background to why I'm interested in wellbeing and mental health in macular disease, and a little bit about the current sort of state of research and state of practice at the moment. I'm now going to move on to the project which the Macular Society are very kindly funding, and this is something which is called the STOMP project, which I'm leading at Moorfields and UCL. STOMP is an acronym I was quite pleased with. It stands for Supporting Teenagers to Overcome Macular Problems. So it's a nice acronym. It's not completely accurate because we're not just interested in teenagers. As I told you a few minutes ago, we're interested in adolescents and young adults as well, emerging adults. But that wouldn't make quite such a snappy acronym. And the questions we're trying to answer are, what is the relationship between macular disease, inherited macular disease, well-being, depression and anxiety? And importantly, how can we improve well-being and decrease mental ill health in young people with macular disease? So the first is a quantitative study. That means measurements, so that means sort of numbers. We're measuring the scale of the problem, we're measuring the association between different factors and well-being and mental ill health. And the second is qualitative. So this means we listen to people with lived experience of the condition. So we're going to recruit people and listen to people who have inherited macular disease. We're going to talk to parents. We're going to talk to teachers of vision impairment. We're going to talk to counsellors. And we're going to listen to what we call experts by experience, which is everybody listening to this talk, really. And work out the best interventions, the best strategies we can have to improve well-being and decrease mental ill health in people with inherited macular disease. So it's a big project, it's a big question, and we have a large team of people who are working on this, some of whom you may have met. So our main study team, that's me on the left there. Next to me is Dr Mark Tibber, who is a clinical psychologist and a lecturer in psychology at UCL, who is leading on the psychological and psychotherapy side of the study. Tessa Decker is also a psychologist and associate professor in ophthalmology at the Institute of Ophthalmology. So we're sort of the scientific leads for the study. And the four people on the right-hand side, there's Dr. Ngozi Oluyonye, who's a consultant paediatrician, a developmental paediatrician, who specialises in vision impairment. She works at Great Ormond Street Hospital and at Moorfields Eye Hospital, so you may have met her. Pitch beneath her is Professor Mike Michaelides, who you may know as a consultant ophthalmologist and professor specialising in inherited macular disease. Next to him is Bernadette Bell, who is a teacher of vision impairment and a family support worker at Moorfields. She's a teacher of vision impairment for London Borough of Islington. And top right corner is Bhavna Taylor, who is a parent of a young person with inherited macular disease, and she also leads the Stargardt's Connected charity. So this sort of steering group, we've tried to create a range of people with different experiences. And the people we're going to recruit, the people with inherited macular disease, we're going to either interview or do these questionnaires on, are going to be recruited from the clinics at Moorfields Eye Hospital. For the quantitative phase, that's the measuring the problem phase, we're going to look first at adults with established inherited macular disease from Mike Michaelides clinics and from the low vision clinics at Moorfields. And then we're going to look at adolescents with newly developed inherited macular disease. So we're going to look at these people from the time of diagnosis through their first year of living with inherited macular disease. As I mentioned before, for the second stage, our qualitative stage, we're going to be talking to experts. That means people with inherited disease, parents and so on, as well as other people involved with the care of people with inherited macular disease. And these again will be recruited through clinics here, but also through the Macular Society and through different groups of people with lived experience of macular disease. I'd like to talk quickly about what we're actually going to measure. As I said before, we're going to, for the quantitative stage, we're going to use these standardized age-appropriate questionnaires, which have been used in lots of different areas of medicine and lots of different types of research. And we're going to look also at some other factors to see whether these predict having better well-being, such as having good social support, such as not being lonely, such as having good relationships with family, with friends, with neighbours, such as having received support, such as counselling or low vision assessment, or the input of a qualified teacher for vision impairment or mobility training. We're going to see which of these sorts of factors maximise well-being. And we're going to look at the level of participation in society, which means things like the ability to perform leisure activities or household activities, or participate fully in education or social groups. And then for our phase of looking at what might help people, we don't know yet what we're going to find and what people are going to have found most useful and what seems to have the biggest impact on our scales of well-being and mental ill health. But I suspect this is likely to include things like proactive counselling, like peer support, like having the support of practical things from low vision clinics, like having genetic counselling, and like having full information about the disease, likely progression, and how the disease works. But we don't know. This is what we're going to ask our experts to find out. So how far have we got? We have full ethics approval for this study now. So the NHS Health Research Authority have approved the study. We are in the final stages of study setup. We expect to start our first participants coming through the study this September, so this month. And we've put together this really sort of good team of people as well. So this is quite a complex and time-consuming and perhaps slightly less interesting stage. And we're now into this phase of recruiting people, asking them to take part and collecting our data. And we expect this to last for about the next 18 months or so of the study. So broadly speaking, we'll be collecting data until the end of about 2024, and we're going to analyse the data until about the summer of 2025. And then very importantly, we want to share the information, share these results with policymakers so that these things we find can be implemented in clinic and in care pathways for people with inherited macular disease, but also really importantly with the community of people with inherited macular disease. So through Macular Society, we hope we'll get on in touch on Radio 4 and so on, and to really sort of spread the message of what we found. So just to summarise the study, we'd like to know more about well-being and mental ill health in young people with inherited macular disease. And I hope I've convinced you that's important and that's interesting and that's something which we should be interested in. And we want to know how we can best help people with inherited macular disease to maximise their well-being. And our two scientific approaches to this are in quantitative measurements, so measuring these factors, and qualitative analysis, where we listen to people with lived experience. And I hope to be back here in 2 years' time to present these results. So it's a very quick thank you. Thank you again to the Macular Society for funding this project. Thank you also to Moorfields Eye Charity, who are supporting us by funding a PhD student to work on a very similar project alongside this, who will be looking at different conditions and also looking at the differences between people with lifelong vision impairment and those who have a disease which presents slightly later in life, like inherited macular disease. So we're going to look at what we can learn from people who've lived with vision impairments their entire lives and see how we can implement some of the strategies which they use more effectively in people with inherited macular disease. And thank you very much for your attention and for listening to this talk. There is a question and answer session now. You may not be aware I've actually recorded this on a rainy Thursday in July, but future me should be present to answer your questions in a few minutes' time. And my email address, if you are interested in more information about the study, is m.crossland, which is CROSSLAND, @ucl.ac.uk. Thank you very much.